This podcast is brought to you by the School of Advanced Study, University of London.
Good evening, tēnā koutou katoa. It's wonderful to be in this fantastic venue tonight. Thank you, Sir Graham, for the opening words, and particularly thank you to Wendy Mead and John Overns for arranging this wonderful venue, which is certainly the most ancient place that I've ever spoken in. And of course, thank you to my panelists, and thank you to all of you for coming along this evening. So the topic, pandemics, stopping pandemics at the border, can it be done? And I thought I would give the opening words to this classic film, Total Recall. So I'm sure John Overns would agree that it was like a typical day at the office. But are there actually some serious lessons from this film? And one of them, I think, is that there's a really pervasive concern for trying to regulate the movement of unwanted threats across borders. And I thought it's interesting that even in 2084, screening was still a concern. Of course, if screening was only this easy, if problems declared themselves so visibly at borders, life would be a lot easier. So this evening, I'm going to talk about some imported disease threats. So what other things we're actually concerned about at borders? And then thinking about some of the research from New Zealand, which is particularly focused on issues around screening, using things like questionnaires and thermal scanning, and then really our real life experience in 2009 and some of the issues around transmission on aircraft. And then really moving into, I think, probably a more extreme approach, which is actual border closures. And this is work we've been doing more recently. And then ultimately questions, can we actually stop pandemics at borders? So my background, I got very interested in infectious diseases working at the National Surveillance Centre in New Zealand and worked with the World Health Organization on the international health regulations, working on the pandemic in 2009, and then on quite a wide range of infectious disease questions at the University of Otago in Wellington. And like a lot of people, I was drawn into the looking at the pandemic. As we said, any public health doctor with a pulse was mobilised to help prevent the entry of this virus initially. And this is just to show some of my extended research team, particularly working in the area of housing and health. And last year we got the Prime Minister's Science Prize for this research. And this is actually the Prime Minister here, John Key, and it gives you some idea of the scale in New Zealand, that politicians are generally quite accessible, which I think is very useful for rolling out some of the results of our research. And one extra stray researcher, my daughter Euphemia, who just happened to sneak into the photo, she's here tonight. So what are the things we're actually worried about at borders? Because not all diseases are relevant. So some of the basic terms that will be very familiar to many of you, but this core idea of epidemic, which is more than you expect. And often we think about outbreaks which are localized and may become more generalized as an increase, as an epidemic, and really a tiny minority that become pandemics, and particularly those that cross borders and ultimately may become a global health threat. So what specific diseases are we dealing with? Well, there are a lot of known human pathogens, more than 1,400. Emerging diseases often come from the animal world and wildlife, and so that really greatly adds to the number of potential pathogens when you build in the range of organisms that infect animals. For example, these are just, I'm going to give a couple of examples from New Zealand. This is, say, imported travel-related disease, dengue fever. And each of these peaks really corresponds to an outbreak in a Pacific island where New Zealanders are currently travelling and returning from. Currently, it can't be established in New Zealand because we don't have suitably competent vector mosquitoes. So this is not yet an introduction threat for New Zealand, but it may become so in the future. So another group of diseases that cross borders are really those that are more related to migration, diseases like TB and HIV/AIDS, which really move with migration patterns. And this is a situation that's probably very similar in the UK, where now 3/4 of new TB cases in New Zealand are in people who've migrated to New Zealand and manifest disease here or in that country. So putting all of this together, I'm sorry it's going to be a bit hard to read all of this. We can think of several discrete pandemic scenarios. We've got a range of infectious diseases that typically cause acute epidemics and pandemics, where there's transmission between people, and diseases like pandemic influenza, of course, are the quintessential example, but we have other less well-characterised diseases like SARS and MERS, the risk of bioterrorist agents, and then diseases where the risk has been largely eliminated but may return, things like polio and diphtheria. And finally, exotic infectious diseases that really have very low transmission potential in high-income countries, but of course are a disaster in low-income and middle-income countries, diseases like Ebola viral disease, for instance. Then we have this other group of diseases that are more related to migration patterns, the HIV/AIDS pandemic, and patterns of antibiotic resistance. And then we're down to other diseases which are more related to the movement of vectors and infected animals, and also contaminated food, drink, and other products. So you can see that functionally these are all quite different patterns. So we may lump them all in together as diseases with importation potential, but they all behave differently. So I'm not going to go through this in detail, but just to point out there are a lot of interventions that you can do at borders, and I'll comment on a few of these. So one idea that comes up a lot is quarantine, and I think it's often a misused term, because when people think about what do we do at borders, they often talk about a quarantine service, when in fact they often mean other things. But technically, quarantine is just a restriction on the movement of wild people and animals who may have been exposed to an infectious source. And it has this wonderful origins in the idea of 40 days. And of course, this is like a lot of practice. It evolved before anyone had any idea that there were even microbes. So it has this amazing history, and I think particularly in maritime countries like Venice, they found that if you had a ship that may have infection on board, if you forced it to sit in the harbour for 40 days, if there was anyone alive at the end, probably they weren't going to introduce any unwanted infections. But a term that I think is more accurate for what we often do is protective sequestration. It doesn't roll off the tongue so easily, but this is really the idea that you might actually isolate or sequester a population of people to protect them from an infectious agent. And it's obviously, it has quite a good history, a well-documented history of success, particularly in the 1918 pandemic, where some communities escaped infection because of that. And then one of the main ideas, of course, is this idea of screening, the idea that you can identify people or animals or products that may be contaminated or infected, and ideally your test distinguishes well people and those who probably have a disease and those who do not. So when we put this together, we can think we've got this range of scenarios and we've got this range of interventions. And I'm not going to go through this in huge detail, but obviously there is an element of trying to select the appropriate interventions for the kind of scenario you're dealing with. One of the things with screening is there's a huge literature on this, and of course your ideal screening test is entirely sensitive. So in other words, it picks up every infected person, which of course is generally impossible, but that's what you aspire to. But if you're going to try and stop a disease at a border, frequently you need something that is approaching 100% sensitive. At the same time, you've always got this terrible trade-off with screening, because of course generally the more effective you are at picking up people who may be infected, the trade-off is obviously you're picking up a lot of people who are not infected. So you start to have this big burden, and it's measured in a number of ways, like the positive predictive value. Ideally that's high. In other words, if you detect someone who you think is infected, they really do have the infectious agent of interest. So of course biology often gets in the way of a great idea, and anyone who's worked with infectious diseases will always be very familiar with the idea of incubation period, the interval from being exposed to actually developing symptoms. And one thing here is it does vary hugely for different agents, and of course with Ebola, you're looking at 8 to 10 days. But again, with all of these agents, the other thing is this idea of a range, that we might quote a mean or median period, but you actually have to be very concerned about this long tail. In other words, it might be, say, for SARS, you might be worried about people who are still incubating disease after 2 weeks. And with Ebola, you're really looking at a range of up to 21 days. So that does create, obviously, huge challenges for trying to contain disease at borders and screen for them. So now I want to really move on to research we've done in New Zealand, really looking at screening. And there's a number of pieces of research over the last few years. So one thing that most travellers are familiar with is the idea of passenger declarations. And this is a very attractive idea because, of course, everyone's sitting on the flight, often for a few hours, nothing to do except watch the movie and have a few drinks, and hopefully fill out the declaration card. And so recording symptoms and maybe certain other things about where they've travelled to as indicators of risk. So we did a study in 2007, 2008 to test out the sensitivity and performance of screening with these declaration cards. And of course you need a gold standard as to whether people are infected with influenza. There is no gold standard, but we did throat swabs and PCR testing for the presence of influenza virus, and also did temperature testing. So basically the passengers would get off the plane, they would hand over the cards, and then they would go for a throat swab and temperature testing using tympanic membrane temperature. So it's kind of a fairly non-invasive testing method there. So I won't go for all the details here, but you start with a lot of people. You potentially include 23,000, and about 2/3 agreed to be in the study, and then various things happen along the way here. But one of the things that was unique in this study, which hadn't been done before, is we also tested a lot of people who didn't have symptoms. And you basically have to do that if you're trying to evaluate the performance of your screening methods. So, as I said, 2/3 of people voluntarily participated. Some were selected for specimen collection, so we got almost 4,000 throat swabs. And a portion had at least one influenza symptom, and about 1% were positive for influenza on a throat swabbing. So if we just look at the performance, the sensitivity and positive predictive value of these sort of tests, you can see here this is the most common symptom, which is any symptom, and that had reasonable sensitivity. That would pick up about 84% of those that were subsequently confirmed as having influenza on a throat swab. But you see the positive predictive value is pretty dismal. So what this is saying is that 95% of people who are identified with that test, that method of screening, didn't have influenza detected. So that's a lot of people waiting around for more assessment. And you can see cough has some benefits, sensitivity drops, but the positive predictive value rises. And so our conclusions from this are that this isn't really going to be a particularly viable approach for influenza. Sensitivity at best is 85%, and you are identifying a lot of people who don't have influenza. But on top of that, you have all of these other serious problems. You have some people won't declare symptoms, or they'll disguise them. They may be incubating disease still, and they have no symptoms to declare, or they may have got infected on the flight, or some of them have asymptomatic infection. So then we added in the other common screening method, which is thermal scanning, infrared thermal image scanning. And as you probably know, this essentially is just a way of taking your temperature on a large scale in a non-invasive way. And we've all walked past these things and wondered what on earth it means in airports around the globe. And so we screened around 1,300 travellers as part of the study, and we could look at the tympanic temperature. That's really measuring their core temperature, and also looking at the performance of this for basically predicting that core temperature and also predicting those that had influenza infection. And you use these ROC curves for experimenting with different values to try and optimize what you could achieve with sensitivity and specificity. The trouble is, again, it's even worse than symptom declaration. It is moderately effective at detecting travellers with a high core temperature, but it still has a very low predictive value, partly because the prevalence of fever is actually very low, only 0.5% in this travelling population. So the portion you're going to detect even with a screening which is moderately sensitive and specific is still a very small portion. In addition, this is the real problem, is that fever is not a particularly good marker of influenza. And in fact, none of our 30 influenza-positive travellers actually had a fever above 37.8, so that wasn't great. And we do know from challenge studies, and Neil Ferguson has actually been involved in some of these remarkable studies, that if you experimentally infect people, you find that a third of them are asymptomatic, and even those who are symptomatic, only about a third have fever. So fever is never ever going to work as an effective screening method. So a year after doing this research, of course, we had the real thing, the 2009 pandemic, which was really a remarkable test of systems all around the globe for managing these events. And so we set up something, I'm not even sure if you'd call it screening. It's a passive form of screening at the two main international airports coming into New Zealand. And in Auckland, over 2 months, it picked up 4 cases of laboratory-confirmed influenza. But our estimates are based on surveillance data and knowing the portion of people who'd arrived from overseas recently, is that the sensitivity was only around about 6% for detecting those arriving travellers. So dismal. It does have other purposes, of course. So another complexity really is this question of influenza transmission on arriving flights. And we noted that on this day, when the public health emergency of international concern was declared, that was a day when pandemic influenza arrived in with a plane load of students coming back from Mexico. And a certain number had symptoms and were confirmed as having influenza, and they were all seated in the rear section, the cheap seats, in a Boeing long-haul flight. And a number of other travellers, the unique thing we could do here is we could follow up everyone on that flight, because New Zealand was still in this containment phase and we had a new virus, so there was a chance to do some quite good field epidemiology here. And so this is the classic seating diagram that everyone does when they're describing these outbreaks, and these were some of the confirmed influenza positive travellers in that school group, and these were people who developed influenza after the flight and were confirmed as having the new pandemic virus. So basically what these data told us was there was a low but measurable risk of influenza transmission on the flight, around about 2%, not based on large numbers of infected people. And that risk was concentrated within 2 rows of those infected travellers. And of course, as some of you may know, that if you're going to sit for 12 hours with people who are coughing away with influenza, one of the best places to do it actually is on an international flight. Because the air is vented out sideways and then is treated in a way that probably inactivates most influenza viruses. So it's definitely better than a bus, I would say. So that's looking at New Zealand research on border screening. And one other area that we are interested in at the moment and are doing quite a bit of work is looking at a slightly more radical approach, which is actually shutting borders entirely. And I'm quoting again from a couple of very major researchers in the field, Neil Ferguson, this is from his really seminal work in 2006, looking at what can you do at a societal level or population level to slow influenza. And I think we'd all acknowledge that border restrictions and control of internal travel is not going to it can slow an influenza pandemic, but it's certainly not going to stop it. And I think Ben Cowling did a nice analysis looking at what actually happened in 2009, looking at countries that did implement some kind of border controls versus those that did nothing. And they concluded that it was plausible to think that this might delay arrival by 1 to 2 weeks. So I think that really fits this picture that I hope I'm painting about the fact that border screening is not really a terribly effective strategy for preventing arrival of something like influenza. But we've also done quite a bit of work looking historically at what happened in 1918. And again, what this graph is showing, and this vertical axis is the death rate per thousand in populations across the Pacific. And this is showing the arrival dates of pandemic influenza. So in a country like New Zealand, about 1% of the population died. But when you're moving up to Western Samoa, around 22% of the population died in the space of a few weeks from pandemic influenza. And unfortunately, it was introduced in a ship from New Zealand. But just about 50 kilometres away is American Samoa, and they introduced rigid border, they call it maritime quarantine, where they let no ships in at all for 2 years. And they had no one die, according to their documentation, from influenza in that pandemic. So we would really say that's protective sequestration is probably the correct way of describing what they did. So we've done also a little bit of modelling work looking at the potential to protect Pacific Islands, because New Zealand still has, like the UK, a few small Pacific islands that are protectorates, and often the only travel to these islands is via New Zealand. So we do feel quite a bit of responsibility for transmitting influenza to those countries. And what you can do is, if you look at quarantine plus potentially rapid testing for around about 9 days, that could prevent the arrival of a new pandemic virus, even if you've got quite a bit of transmission in the source countries, but for fairly modest numbers of travellers. So quarantine can work, but only when you in very specific situations. So I just really want to finish by talking about some work we're just doing at the moment, which is really looking at an economic assessment of complete border closures for countries. And this considers the costs of closures in terms of net tourism revenue, because in fact there are ways you can shut borders and still keep trade working very effectively. The benefits are using health metrics of deaths averted and health system costs saved. And we're monetising the qualities using fairly standard approaches that WHO would use, and looking at a number of scenarios. So what this shows is that if you have a moderate pandemic scenario like what we had in 2009, it's not cost beneficial under any circumstances to shut borders. However, if you move to a 1918 type event and we halve the case fatality risk based on improved medical management, it's highly cost beneficial to shut borders with huge economic savings. And of course, an extreme event that's, say, 10 times the case fatality risk of 1918, again, it's again huge, obviously greatly increased economic benefits. We're partly using economic metrics because of the fact that often the resistance to taking public health measures is couched in economic terms. This is showing the same kind of conclusions graphically, and this is showing pandemics of various forms of intensity in terms of the portion of the population who might die, really from a 1918 type event through to something far more extreme. And this is showing the weeks of border closure that would be economically justified. So what this shows that even if in a fairly only a moderately extreme event in some terms, could justify closing the borders for 2 years, just using this quite simple model. Now, we are really using this very much as a proof of concept, and as you can see, the value of border closures is mainly driven by the valuation of lost life, so the number of deaths you could avert by shutting borders entirely. But certainly it can provide huge health benefits and also cost benefits if you can achieve 100% closure, which of course is one of the challenges. We've run this modelling with a number of other island countries and we get very similar conclusions. So as I'm saying, this is really a proof of concept. We're not saying these are absolutely precise values, but we do think that for countries where it's technically possible to do this, that border closures really should be on the menu of options. One of the I think the international health regulations are a fantastic advance in global health security, but one of their elements is to try and prevent countries overreacting and to try and have some evidence-based consistency in approaches that are taken. And so it has this idea about containing the spread of disease in ways that are commensurate with and restricted to public health risks and avoid unnecessary interference. So I think we'd all support that, and so we really want to see hopefully an informed debate about the role of border closures. So what pandemics can we stop at the borders? I think it's very sobering to think about the context and what do borders mean for many countries. And I think these remarkable images from Africa really show that the idea of border closure, where they're so porous, is fairly absurd in some contexts. Also, if you've ever done any work, and I know a lot of the people in the room here have done a lot of work looking at the border context, it is the most highly regulated strip of land on the planet in many cases, with multiple agencies and jurisdictions, multiple functions, and many different political and administrative issues, and it's also dynamic. It can change very swiftly. So when we think about going back to these big scenarios and the kind of measures, we can think that if we think about most of the diseases I'm talking about are those that really have quite rapid onset and person-to-person transmission, the classic pandemics. We're really very limited by biology and geography in terms of what we can do at borders, but at the very least it is a great opportunity to educate people about the features of disease and also look at following up people with symptoms. So there are definitely benefits, but it has to be balanced against the other uses for these resources. Obviously with diseases with longer latency, it can be highly effective, but again you need suitable human rights safeguards. And with products and animals and vectors, we know these measures do work in terms of limiting the spread of what used to be huge pandemic problems like plague. But again, there are limitations. I think we're living in a world which has got increasingly rich global health data, and this was just one example of the way data were looked at in terms of the risk of importation of disease during the UK Olympics. And I think some very sophisticated approaches for trying to tap into these data. So there's a long list of challenges. I think trying to use the data we've got more effectively, generating evidence about what works at borders, the potential role of border closures. I think we really need to be much better at engaging with airlines, because after all, airlines as an industry are the most sophisticated risk assessors and managers. There's two risks they manage. They used to manage one risk, planes falling out of the sky and crashing. Then they added the risk of terrorism. And at the moment, they're highly resistant to a third risk, which is the risk of disease transmission. But I think we do need to engage them. They are extremely good at finding clever ways of managing these sort of risks. I think the potential for global consensus building through the IHR process is brilliant. We just have to try and use it consistently. And human rights are very important. But certainly one thing I've been impressed in my time in the UK is really learning a lot more about the global health security agenda and really working to try and contain these diseases at source and ensure that everyone on the planet has access to high quality health services at the point where they really need them. And I'm just hugely grateful to a long list of people who've helped me to get here today, particularly the New Zealand UK Link Foundation, which has been brilliant, Lisa Fletcher, who's done an absolutely fantastic job organising these remarkable venues, my hosts and staff here in the City of London, the panellists who we're going to hear from shortly, and a large collection of New Zealand colleagues, and of course my university and a range of funders. Thank you very much.
Thank you very much indeed, Michael, for a very thought-provoking and logical lecture. Before I introduce Neil Ferguson, just a few words on how the evening is going to pan out now. What I'm going to do is ask Neil to respond initially. We'll then be inviting the panellists to the stage, and just to give them prior notice, I'd like them to just a couple of minutes each on their response, particularly to the challenges that Michael said about the borders. So perhaps I'll ask you to give your response on that as well. We'll then throw the floor open to questions, and there'll be opportunity for you to consider what are the most important elements for you. So, first of all, though, over to Neil Ferguson from the Department of Infectious Disease Epidemiology at Imperial College.
Thank you, and thanks for the invitation to be here. So I run a research centre at Imperial College, the Medical Research Council Centre for Outbreak Analysis and Modelling. And for many years, we have been advising, as well as doing basic research on infectious diseases, we've been advising UK, US governments, the World Health Organization on how to plan for and prepare and then respond to what are called emerging infectious disease threats. And so one of the things we have looked at quite extensively in the past has been border-based infectious disease interventions, partly because, as we'll see, they are an instinctive response of many policymakers. And I think Michael gave a very nice summary of then turning that instinct to impose those things into a more considered judgment of whether you're investing money and resources wisely in doing so. So I think it's worth stepping back and just considering the scale of the issue. The graphic you see here is a network diagram of the global air travel routes worldwide and travel flows. There were 3.3 billion air passenger journeys last year. That's projected to increase by 2030 by twofold at least. Even if we consider the UK as a whole, we have 237 million air passenger journeys connecting somehow in the UK. And then on top of that, 40 million ferry and Eurotunnel passengers. So we have we're one of the most connected countries on the planet, if not the most connected country on the planet in terms of both the numbers of passengers and numbers of destinations. So it's in some sense, it explains, well, absolutely does explain why we always get infected with certain diseases first. We were the first country in Europe, for instance, in 2009 in the flu pandemic to be affected after Mexico and the United States and Canada were across the Atlantic. And so it is a major issue, and so it would be natural for us to think about the potential impact we could have on our risk of disease from imposing screening border restrictions to reduce spread. Stepping back a little, though, one thing we do know from recent data and events is that people reduce their own risks in response to infectious disease emergencies. We certainly have seen that in response to Ebola in West Africa. People, even before they were advised to, stopped travelling there. We saw that before in the SARS epidemic in Hong Kong, in Asia more generally in 2003-04, where there was substantial, and what I'm plotting here, and I'll just highlight, are different data on travel volumes relative to kind of baseline average here, on travel volumes measured by IATA, the Travel Association, for overall globally, and then Asia-Pacific region, and then Hong Kong airport. And you saw, coincident with the rise of cases shown in red here, something like an 80% drop in travel to the affected areas, to and from the affected areas, even before the World Health Organization issued travel advisories. And so that drop in travel has much the same effect as a screening measure which is 80% effective. Namely, in theory, it has some impact on the risk of spread, but it's not at a level which is going to do more than delay the spread of the disease. So before I talk about what impact you can expect to have and why you should be doing it, from a policy perspective, we have to ask the question, what do we want to achieve through any sort of border screening, border intervention? Because they are always very costly in terms of time and personnel. And there's an opportunity cost involved. We could use that same resource in doing something else. Those public health doctors in particular are a rare resource and could be deployed in arguably perhaps better ways. So we need to think carefully about goals, and this is where I think even in the last 12 months we've not been terribly good. The US, the Obama administration introduced border screening for Ebola in the United States on the grounds of reducing risk. And that really isn't a well-defined goal. And what are you trying to achieve? Prevent all infection from entering? Well, they clearly have failed in doing that. The hugely expensive program they put in place hasn't detected anybody infected on the border, but they have had imported cases. Or you're just wanting to reduce the risk by a bit. You need to consider these things in a quantitative, in a monetary sense, as Michael has started to do with his research looking at border closures. There are benefits. You may be able to delay the arrival of a disease. You may be able to get valuable data from picking up cases early. But you need to consider them. So I'll consider just quickly two scenarios, which are the ones Michael has really focused on in his lecture. One is a pandemic scenario. 2009 Mexican flu. We have a new flu epidemic. We don't know very much about it in the first few weeks, and so people are scared. How dangerous is this new virus? We don't really have data on deaths. A knee-jerk reaction is then to go for some sort of containment scenario. You try and detect cases on borders, heighten surveillance at home. We did a lot of modelling of this well over 10 years ago now of how likely it was to be an effective measure. When you have a disease, an epidemic, which is growing rapidly in a source country where you can't control it. So what you have is, in one area of the world, a growing epidemic, which is going to affect, let's say, a quarter of the population in the first year. So very, very large numbers of cases. And that modelling and simple arguments say that even very effective border controls can only delay the arrival of the epidemic on your shores. And the reason is that the risk of arrival is not proportionate to what proportion of cases you get. It only takes one infectious person to get into your country to trigger the epidemic there. So what you're really trying to do is stop that first case, an incredibly hard thing to do. So the delay, the impact depends on the effectiveness, or the delay you achieve depends on the effectiveness of the intervention, your border screening, and then critically something else, the doubling time of the epidemic in the source region. So for flu, 2009, that was about 3.5 days. What that means is the epidemic grows in size, number of infected people double every 3.5 days. So if your border screening is 50% effective, you buy yourself that doubling time. You buy yourself 3.5 days delay before the epidemic takes off in your country. 75%, you buy yourself a week. 85%, perhaps 10 days. And this is very much in line with the sort of estimates which were referred to in Michael's nice lecture and have been measured or estimated by Ben Cowling. So to really buy us the sort of delay we would like to have in the case of a lethal pandemic where we don't have vaccine and we need to manufacture it quickly, we want to buy ourselves months of time before the epidemic takes off. And that's where you get to these you need these very, very effective measures, 99% reductions, effectively closing borders. And that, of course, is highly expensive. When we're talking about an emerging infection outbreak, and classic examples here would be SARS and MERS, which had some pandemic potential but were not large scale. Ebola, a disease which actually we thought until this last year we knew how to control Ebola outbreaks. We certainly know how to control them here. The reason it's been catastrophic in West Africa, where I'm visiting next week, is because of the very limited healthcare infrastructure, level of education of the population, and the fact that not enough was done early on. But if we have Ebola cases arising, coming into the UK, we know how to stop Ebola spread. So in that context, you have to say, why would we consider border screening for Ebola with a long incubation period? It's highly likely people will arrive, even if they are infected, without showing symptoms. Much better is to enhance, as we have done, and this is a Public Health England, NHS England, should I say, poster, enhanced surveillance in primary care centres and in hospitals where if people start showing the symptoms, then they're picked up early, travel histories are taken. And so you need to assess how easy containment would be before you impose these restrictions, and for Ebola it is easy, albeit expensive, but you always have to do it. And then evaluate what's the most cost-beneficial use of resources in reducing the risk. And I would argue that wasn't done this year in the UK, for largely political reasons. There are other contexts where the judgment is harder to make. MERS coronavirus is a real issue in the Middle East now. It's a new novel coronavirus pathogen, a bit like SARS. It could maybe cause a pandemic, we really don't know. And it's a respiratory-borne disease, and so harder to contain spread. So it's not a completely black and white issue, but given the limited effectiveness of screening for respiratory diseases at borders, one still, even there, wants to hesitate. So border-based controls are a blunt tool with quite limited effectiveness and high cost. They're a politically attractive tool, and I would argue that's because politicians show the population they're doing something. They have no vaccines, they have no drugs, but we can screen people at borders. But really, we want policymakers to be evaluating the costs versus the benefits. What could they do with that same resource, which maybe is less high profile, but has a bigger impact? The other problem is once you've introduced these controls with rather fuzzily defined goals, it's quite hard to de-escalate them. CDC is struggling in the United States at the moment to find a rationale to give to the White House for stopping doing their Ebola screening, which is costing millions of dollars a week. Nobody in CDC I've met feels it's a useful use of resources, but since the goal which was set was zero risk, it's very hard to get away from a policy and accept some risk. All that said, I completely agree with Michael. There may be extreme scenarios we haven't encountered where we need to have done planning in advance to say, is it feasible to impose really effective interventions? But we need to recognise those would have enormous economic and social cost, and may indeed, given our limited stocks of many critical items like both food, pharmaceuticals and the like, may not be feasible in many contexts. Thanks.
Thank you very much, Neil, for those observations. I'd now like to invite the panel members to take their places at the table, please. And whilst they do so, just a few, do go up there now, and I'll just say a few words of how we'll run the question side of it before I ask you to say a couple of minutes worth each. When we come on to the questions side, if you could kindly give your name and what organisation you represent or what interest you represent, and by all means make some observations, but we do want to get to the questions as quickly as possible because we have a very eminent panel before us today, and we want to hear what they've got to say. Just to introduce them then, from the far side is Dr. Nicole Black from the Public Health England, the consultant in communicable disease control. Then there is Matthew Balsingham Chandra Kumar, and he's a Port Medical Inspector at Heathrow. Then we're very pleased to welcome Professor John Watson, Deputy Chief Medical Officer at the Department of Health. Then from the home team as well is Deborah Turbett, who works in London as the Deputy Regional Director, and the other two gentlemen you know. So in getting them to have a few words to begin with, I'll start with the more policy-based people. So perhaps, Professor Watson, you could just have a couple of minutes on your observations on what we've heard tonight.
Thank you very much. And I must confess, I'm going to repeat a number of the things that Neil has said. Clearly, an infectious disease will emerge over the coming years somewhere in the world that has a pandemic threat. Fueled by the Daily Mail and our other organs of our very efficient media, there will be public reaction and concern, and the politician's instinct is to act. Unfortunately, what seems logical is not always so, and as we've heard, often the measures that seem logical are ineffective. They may provide false reassurance. They're certainly expensive. They may have unintended consequences, and they may be discriminatory. And so I think that decisions need to be informed by clear objectives for what you're doing and cold, hard facts. The recent Ebola outbreak, as you will be aware, screening was introduced at UK ports. That screening process had a number of objectives and had a number of elements to it. I think it's going to be really important to review carefully the usefulness, the effectiveness of that screening that took place and its cost, and apply that learning to further threats so that we can act rationally and proportionately to those future threats. And at the same time, we need to make absolutely sure that our NHS and our public health services are prepared and able to deal with any threat that comes along. Thank you.
Thank you very much indeed for that. If I can pass over now to Nicole Black, please.
Yeah, I think by definition, you can't do anything with a pandemic because the natural history of something which is going to spread so quickly means it's there before you know it. I mean, 2 million people cross an international boundary every day. The disease is introduced long before you even recognise it's there. So pandemics, face aft and salute, you've had it. Don't get too despondent. You can actually do quite a lot of work with containing or reducing other diseases. And if you're an island like UK, or even better, if you're a faraway island like New Zealand, you've got a great border. You can actually do some things with it. And probably one of our success stories is controlling tuberculosis. New Zealand, like the UK, a majority of people who have tuberculosis in the country are people who are born abroad. Well, folks who are born abroad, who are coming from areas of high incidence of disease. You know, we've moved, for instance, from screening people at the border, which was a really messy affair at Heathrow, to screening them before departure. And we've had a programme in place in the UK now for about 2 years, and it's made a dramatic reduction in the number of tuberculosis cases arriving in the country. So I think, you know, in terms of borders, you should think, what can you do pre-departure? And I think the big success story with Ebola is I think the pre-departure screening was obviously very effective. We simply have not seen very many cases arriving you know, out of West Africa. So there's pre-departure, there's on arrival, and yes, all these technical difficulties on arrival are almost insurmountable. You'd have to have a disease with an enormous fatality rate like smallpox to make it justifiable, I think. And then what you do in country. And I think it's getting the balance of those three together is where you get the most effective strategies.
Thank you very much. I can now ask Dr. Chandra Kumar to give his views, please.
Thank you for that, Chairman. I agree with my colleagues. I think everything depends on the disease we are talking about, the transmission, the natural history of the disease. For something like pandemic flu, as Nicole quite rightly pointed out, with global travel, it will be almost impossible to control at the borders. However, diseases is something like Ebola, where it is possible with long incubation period, and with high fatality rate, it is possible to bring some sort of control, both pre-departure screening as well as screening at the borders. As far as policy is concerned, obviously that is for politicians and the government to make the policy decision whether we implement border control or not. What the Ebola screening experience has showed us is that we were instructed to start screening on a Friday, and we started screening on a Monday on a huge scale. So it is possible to implement a screening program. Myself, from the point of view of implementing, we are confident that we can implement measures if it is necessary. Thank you.
And finally, Deborah, please.
Thank you. I was reflecting during Michael's presentation on how we responded to the 2009 flu pandemic and how useful screening was or would have been then. And there was certainly a demand from the government to do screening from the passengers arriving from affected countries. We managed not to do that, but did put in place some measures to identify cases very early. And even with those measures, when we asked people to be tested who had travelled from one of the affected countries, had symptoms of flu-like illness and a temperature, and they were tested, even in the very early days with very strict criteria, we only about 10% of people arriving from Mexico with a fever, with cough, with respiratory symptoms actually had flu. So if you sort of the flip side of trying to do border controls would be there's an awful lot of people arriving every day with temperatures who do not have pandemic type illnesses, otherwise we'd be overrun on a fairly regular basis. I think, just picking up on what's been said about Ebola, if we were to, I think, do something about screening again, the screening for Ebola has been very targeted. So it has been, we're targeting people coming from the affected countries. We're not doing entire plane loads of everybody arriving. And what has worked is being able to give those people the correct information to get into the NHS safely if they do develop symptoms. And so since last October, when the screening developed, we have picked up some people at airports with a temperature and referred them safely into the NHS so that NHS workers were protected during that process. And we've tested around about 250 people who've arrived back like that from the affected countries. And all of the people that have been picked up at airports have tested negative for Ebola. What was effective was giving the correct information to returning exposed people about what to do if they became ill. And so that the one UK diagnosed case which arose here was a nurse from Glasgow who, having got the correct information on entry into the country, then used the correct procedures to get into the NHS safely and didn't put other healthcare workers or people in the community at risk. So I think it's probably not at all cost effective, but there was a benefit to doing that.
Okay, thank you very much, panel members. I'll now throw it open for questions. We've got 20 minutes or so. We've got two roving microphones. We've got Brian on this side here, and we've got Clarissa over there. So do wait until the mic arrives so that we can all hear you. So, first question, please. Lady here. And do give your name and organisation or interest, please.
Yes, my name's Dr. Hilary Pickles. I'm retired now, but my last post before I retired was Director of Public Health for Hillingdon, that includes Heathrow Airport. And I was wondering if Michael Baker can respond to comments that both, particularly Neil and John made, and tell me what they think the scientific community should be doing to help prevent more of those knee-jerk reactions from politicians.
That's an easy one to start with.
Well, firstly, I think controlling politicians is always a challenge. I think as scientists we have to give generate the best evidence we can and present it as clearly as we can. And I think probably most people on the panel here, a large part of their jobs actually is communicating with decision makers and politicians, trying to, I guess, contain the worst excesses of policy overreactions. In addition, I guess I'm an optimist about the international health regulations because I think it's the first really solid attempt to have globally consistent, evidence-based risk management or risk assessment and management. It will still not stop some countries doing crazy things. I mean, New Zealand was one of the early countries to have the 2009 pandemic, and we had some of the reactions I think that our trade agencies had to deal with were remarkable. Like the Ukraine banned apple importation from New Zealand. No one in New Zealand has any idea why, but they did. So I think that's always going to be one of the challenges. But I don't know if others on the panel have some views on the art of communicating effectively in crises.
Yeah, John, would you like to comment first?
I wasn't going to comment on the art of communicating in a crisis. I was going to pick up on if I may, on the international health regulations, which is to support the view that this set of regulations, which, as was mentioned, were revised relatively recently, some years ago, are a very important mechanism that to encourage, enable countries to declare early and share information early about threats emerging at a very early stage and let others know so that action can be taken before things get out of hand. That's all very well, but some countries are more able and some much less able to have the kind of surveillance and other sorts of reporting mechanisms in place to achieve that. And so what I think is one of the more important things that are going to help us better anticipate and deal with pandemic threats in the future is the work that's now underway to try and support many countries around the world in the way in which they can deliver on the international health regulations. And so there's now a big multinational effort, the Global Health Security Agenda, which is about developing and providing support to countries to build up their infrastructure so that they can deliver on the international health regulations, can have in place the kind of surveillance that allows them to recognize a problem and share that with the rest of the world promptly.
Thank you. Let's take another question now, please. Yes, in the front row just there.
I'm John Ambrose from the London Port Health Authority. I'd like to hear what the panel thinks about the international health regulations. They've been there for 10 years. Do we need to have a review of them, given it's taken nearly 50 years since the last review, and what changes you would like to see in them?
Who would like to kick off? Nicole?
Short answer, no thanks. There is still an enormous amount of work to do to get the international health regulations in even the most basic forms bedded in. Many Western countries and the UK basically didn't blink. You know, everything that was in the IHRs, we could say yes, 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 really without making any changes. That's just not so in many parts of near Europe. And certainly when you get into, developing countries, it isn't. I was at a WHO meeting last week in Lisbon, related to the IHRs. It was actually about the communication network that WHO, the travel section in Lyon, set up. There are something like 1,800 designated points of entry around the world. And these are supposed to be the nominated specialist ports or airports for each country to deal with public health emergencies of international concern. This particular meeting was the Ports, Airports and Ground Crossings Network, a communication network. And with 1,800 designated points of entry, PAGNet only has 360 members, 60 of which are in the UK. And that's taken 4 years to get that far. So that's just a tiny, tiny example of how far there is to go. And I think most people sign up to the idea that not just preventing infection coming into your country, but also protecting the health of travellers and protecting the country that a ship or an aircraft is moving on to when it leaves the UK or leaves the country. I think most people sign up to that idea. It's just getting it put in practice. A lot of work still to do.
Yeah, I'll just make a couple of comments. I mean, I generally agree that large-scale revision I don't think is needed, and really what's needed is better enaction of what we have. I mean, the outbreaks I've been involved in recently, MERS, coronavirus and Ebola, where we work very closely with WHO and analyse the data they get. One of the major challenges, in both cases, they fell within the remit of IHR, and one of the challenges WHO faces is getting prompt and accurate reporting of cases from countries. Sometimes that's the lack of data and lack of information comes from a lack of capacity in those countries to actually deliver that information. More often, I have to say, in my experience, it's down to a reluctance by those countries or individuals and networks in those countries to share information externally, and that's been particularly the case, say, in the early stages of the MERS coronavirus outbreak, say in Saudi Arabia, where only very patchy data was coming through. I think the second thing which needs to be reconsidered, and there's no right answer here, is what's the definition of a public health emergency of international concern, and how promptly is it declared? Ebola a lot of criticism has been made of WHO for declaring it a public health emergency of international concern too late. Neither do we want people to cry wolf too often, declare it too early. So, I mean, it is a real challenge.
Thank you. Can I take another question, please? Yeah, gentleman over there.
Pardon me. Ivan Atanesov, retired. It's not intended to be a provocative question, but how often does misdiagnosis occur? Thinking of perhaps scurvy, not that I know much about it, could be Ebola in its early stages.
Deborah?
The tests we do have for Ebola in this country have been very well established and worked out and have a very high degree of sensitivity and specificity. So I think if somebody is symptomatic and has returned from one of those countries, we've got some very efficient testing in our national laboratory, and that's where all of the testing has been done, certainly at the beginning of the Ebola outbreak. And I think the scientists are confident that there wouldn't be a misdiagnosis of Ebola. As I said, we've tested around 250 people who met the criteria, and they've all been negative. Most of them have had another disease that was fairly easily diagnosable, like malaria or a gastrointestinal infection. So I don't think we would miss it.
Okay, thanks. Gentleman in the red. Just wait for the microphone and we'll be able to all hear what you say.
Sharma, I have no affiliations. Two issues. One is that the panel has not discussed the way things come out break down. Illegal immigrants. It's just as well having border controls. When you look at the Dover and lorries there, there's a total breakdown. There's boats coming from Africa into Italy, total breakdown. And while you're talking about control, border control, what do you think is going to happen there? And secondly, on the question of symptoms, most people who start getting fever or cough or whatever, they don't sit back, they take symptom relievers.
Who wants to start with that one? Deborah?
Certainly, it was a concern during the recent outbreak of Ebola, but it's a wider concern. When we have looked at migrants and asylum seekers, particularly people who are coming into the immigration removal centres, on average, from leaving their country, the country that they're departing to come here and to seek asylum, on average, it takes people 4 months to get into the UK because of the routes that they have to take. And apart from things like TB, which can have a long incubation period, and HIV, most of the highly infectious diseases have a very short incubation period. So for things like Ebola and pandemic flu, I think the issue of migrants and asylum seekers is not particularly relevant.
Why feel about illegal immigrants who are not following any procedures?
I think even for the illegal immigrants, for the length of time it takes them from leaving the country of origin to getting into the UK would probably negate most of the infectious diseases.
Do you have data for that?
I don't have it myself, but I have seen that data, yes.
Did you want to comment on that as well?
Well, just to add, I think our most valuable protection against infections of that kind, that somebody who's come to the country by whatever means it is, illegal or otherwise, ultimately our best protection is the strength of our health service, that we have a strong clinical and public health service, that when people present, that the people they see will think of the possibility of an infectious disease, can get a diagnosis made rapidly, can ensure that somebody is cared for in a way that they won't infect others, and as well as being provided with effective treatment. So the most important thing, and we saw this in Ebola, a really key part of what we did was to try to ensure that healthcare workers across the country were aware of the issue, what to look for, what to do, and how to protect themselves and others.
Thank you. I'll take a question on this side. I saw a hand over here somewhere, I thought. Maybe I didn't. There's a lady there.
Thank you very much. I was a nutritionist. I have to very careful before I'm talking. So please understand. I think the SARS and MERS and then the Ebola is, if I say, this is only my opinion, scientists created, this kind of disease. The reason why, look in now South Korea, there was a marriage now spread. One businessman went to the Saudi Arabia. He said now Korean scientists and politicians all now invest. Did you touch it to the camel? He said no, even he didn't go there. Also surround him so many Japanese businessmen, Chinese, even the British businessmen, so many people. Those people didn't take it. How the only South Korean men, brought that disease? That is impossible. Also, secondary,
Sorry,
the
can I ask you to come to the question, please? Can I ask you to come to the question, please?
My question is, I think some, this is maybe political reason or economic reason or geological, the world reason, Scientists created that kind of disease. This is my opinion. In 2003, in China, suddenly, the SARS disease was, spread. The reason why...
Excuse me, could I stop you there, please? Because you've had the opportunity to say quite a lot. So I think perhaps we'll deal with that question afterwards. There'll be ample opportunity to talk to the panel members, so perhaps we could do that then, if that's okay. Thank you. Any other questions, please? Yes, gentleman over there in the middle.
Hi, I'm Paul Richards from the Society for General Microbiology. We've talked quite a bit about individuals or people bringing diseases in on flights, but obviously a lot of these diseases are zoonotic, so they can be transferred by animals such as mosquitoes or maybe even livestock, with higher global trade and climate change and stuff like that. I wonder if the panel have any thoughts on sort of diseases being transmitted across borders by maybe wildlife or those routes rather than people taking flights or transport.
Any takers for that one? Nicole?
Yeah, I'll have a stab at it. Yes, you've probably all had the experience of being on an aircraft when it's coming into land and they tell you that someone's going to come through the cabin spraying, for insects. And you think, okay, that's got a bit of logic to it. And, then you travel to the same destination on a different airline from the same place and they don't spray. The IHRs are delightfully Delphic on this. They recommend, vector control coming from an affected area. And in the 10 years since IHRs were revised, WHO has never defined what an affected area is. So it's left to the individual airline to decide whether they do, or the individual country. So some do and some don't. So you either get criticised for spraying and you're giving all these people asthma and irritating their eyes, or you get criticised for not doing it. You're putting people at risk. Goodness knows, it probably has much less effect than people imagine for most parts of the world, but clearly in some, I would imagine in places like Central, America, South America, it probably has a fairly major effect. What is of much greater concern, and only relatively recently being recognised, is the threat posed by ships, particularly when they take on ballast water in somewhere exotic, and then they discharge that ballast water inside a coastal area. And there have been, some introducing, parasites and, vectors that simply have not been, not indigenous to that area. There was a lot of destruction in French oyster beds, a couple of years ago. So that sort of introduction of vectors, introduction of new parasites, because of the tremendous global trade by ships and aircraft that we have, there's a fairly significant threat, and that's only set to increase. Most predictions of global trade are going to say it'll something like triple in the next 20 years. So yeah, we're going to share exotic parasites, exotic vectors on an increasing frequency, I think.
I'll take a couple more questions. Graham, gentleman here in the striped tie just at the front there. Please, Clarissa.
Thank you. I'm Graham Dukes. I'm Chief Executive of the Chartered Institute of Environmental Health in the UK. And it was just a question about detention powers. First of all, in terms of for suspected ID cases at port of entry, are they, or does the panel think they're valuable, appropriate and needed?
Any thoughts? Heathrow, what would you like to comment on?
Could you repeat the question? I didn't get it.
Detention powers, and are they useful?
Detention power, yes.
Yes, the question was about detention powers and whether or not they're appropriate, valuable and actually needed.
We have the aircraft regulation, ships regulation, and the train regulations under which we operate. The medical officer or the proper officer who has been appointed by the local authority has got powers under this for various functions. For example, they can even quarantine an aircraft or ship if necessary. So those powers are there. But I don't think it has ever been used from my living memory because it's quite an expensive business if you do. So we don't use it. Having said that, recently, taking Ebola as an example, it was made mandatory, and if somebody refuses, we were able to just advise them that it's compulsory, and then so far we haven't had any problem. Everybody complied.
Okay, final question. Gentleman there, might take one more at the back before we go.
That good border screening will only delay the introduction of the first case, and that of course does buy time for developing a vaccine. But isn't it the case that with poor border screening, the point at which the disease is identified is when there are several simultaneous cases, and of course it's much harder to control an epidemic of 20 cases rather than one case.
I think the issue is that we can't control those diseases. So there's no concept that once a new pandemic disease arrives in the UK that we're going to control it. The only benefit might be if we achieve some delay in manufacturing vaccine, if there's sufficient delay. But we have a detailed pandemic plan of how we respond to influenza pandemics in terms of reducing the burden of disease and death and its impact. But none of those plans involve really containing a pandemic once it arrives on our shores.
Yes, I suppose I was just thinking about, I'm not an expert in this area, but reducing the contagion effect.
Yeah, I think UK in 2009 had something it described as, and John will remember it well, the containment phase of the pandemic. What we now know is that PHE, despite its best efforts and huge resources applied to it, was probably detecting 1 in 10 cases or fewer at that time. So I think we've learned lessons from that about how we would redo it. The real value of those intensive early efforts, case investigation, contact tracing, taking tests, is actually understanding what disease you're dealing with, how much of a risk it poses. That critical early data which allows us to characterize a new pathogen. and PHE back in, it was HPA then, back in 2009 did collect invaluable data, which was used to inform then the later pandemic response.